All right, good morning, everyone. We're just getting started. Want to welcome everybody to the Diabetes in Special Populations National Learning Series. We will be getting started in just a minute or two. I want to welcome everybody as people are getting settled and signing in. We're going to start in just about 1 minute. So welcome to our Diabetes Continuum of Care, Improving Diabetes Care and Health Equity in a Changing Healthcare Landscape webinar. We will be getting started in just a minute. All right, good morning. We're going to go ahead and get started as we have a full agenda this morning. Welcome, everyone. My name is Cindy Selmy. I am from Health Outreach Partners, and I'm happy to welcome you today to our third in a series of webinars for Diabetes Continuum of Care. Today's webinar is Improving Diabetes Care and Health Equity in a Changing Healthcare Landscape. Next slide, please. I want to introduce our faculty and moderators for this webinar today. First, I'd like to introduce Ariel Mather, Program Manager from National Center for Equitable Care for Elders. Jamie Blackburn, Senior Program Manager from the Corporation for Supportive Housing. And Virginia Vedalago, Program Manager for the National LGBTQIA Health Education Center. Thank you for organizing this great webinar. We're excited to get started. Next slide, please. Just a few housekeeping items for today's presentation. Everybody will remain muted. And we ask that if you have any questions that you please put them in the question and answer section of your Zoom bar at the bottom of the screen. And if you would just let us know who's here today by writing in the chat function your name and health center. We're excited to welcome you. We would like to see who's with us in the room. Next slide. Just a few notes about our diabetes series. Diabetes affects more than 34 million people in the United States. It has been proven that multi-tiered efforts are critical to treat and control diabetes, especially in vulnerable populations. According to the UDS data, 1 in 7 patients has diabetes, and 1 in 3 has uncontrolled diabetes, creating very unique challenges for our community health centers and other health centers in the health center program. 14 NTAP organizations have formed the Special and Vulnerable Populations Diabetes Task Force to elevate the conversation, engage health centers, primary care organizations, and health center control networks to increase knowledge on effective strategies to address diabetes. This fall's learning series, sponsored by HRSA, the Health Resource Services Administration. And please visit our website for more information. Our web address is chcdiabetes.org. I also would like to thank all of our NTAP partners. You could see all of the 21 health center, or the 14 organizations that make up that Special and Vulnerable Populations Task Force. We've all participated in this series this fall, so thank you very much. Next slide. So this is number 3 in the series, the Diabetes Continuum of Care, Improving Diabetes Care and Health Equity in a Changing Healthcare Landscape. I want to invite you to join us for the final webinar in our series next Wednesday, November 10th. This will be our first time doing a webinar 100% in Spanish. This webinar's title is Diabetes Continuum of Care, Addressing Diabetes Management During a Disaster. And as I said, it will be in Spanish. And natural disasters, disease outbreak, and other emergencies can happen at any moment. The difficulties encountered by many people with diabetes and their healthcare providers in the wake of public health emergencies have been highlighted during the COVID-19 pandemic and serve as a reminder to providers and people with this condition to be prepared for unexpected events that may seriously impact their disease management. During this webinar, participants will learn about strategies to mitigate the impact of natural and man-made disasters on persons living with diabetes. And as I said, this will be our first time conducting a webinar in Spanish. Okay, next slide, please. We are offering CEU units today through the Migrant Clinicians Network. They are an accredited and approved provider of continuing education by the American Nurses Credentialing Center Commission on Accreditation. And in order to receive these units, you must fill out our evaluation at the end of the webinar. We will put the link up as well as a QR code. You will receive an electronic copy of your certificate once it has been verified. Please plan for approximately 6 weeks after the end of the series. If you have any questions, please reach out to Jillian Hopewell at Migrant Clinicians Network. All right, next slide. None of the presenters, moderators, or faculty today have any conflict of interest. None of us have any interest related to the presentation, any relationships with pharmaceutical companies, biomedical device manufacturers, or other corporations whose products or services are related to pertinent therapeutic areas. Next slide. I want to take a minute to acknowledge the COVID-19 pandemic and its effects on people living with diabetes. Health centers have played a vital role in the national response to the COVID-19 virus. COVID-19 resources for health centers by all 20 of our NTAP partners are located on the Health Center Resource Clearinghouse. Please see the website for the clearinghouse. Next slide. People with diabetes are not more likely to get COVID-19 than the general population. People with underlying chronic medical conditions such as heart disease, lung disease, or diabetes seem to be at higher risk for developing more serious symptoms and complications when infected with the COVID-19 virus. If one's diabetes is well managed, the risk of getting severely sick from COVID-19 is about the same as the general population. We want to encourage everyone to stay healthy during these uncertain times. Please wash your hands, wear a mask, and consider getting the COVID-19 vaccination. Next slide. All right, I'm going to turn it over to our faculty, Jamie.
Great. Thank you so much, Cindy. Welcome, everyone. Good morning or good afternoon, depending on where you are located. Thank you so much for joining us. I just want to take a moment to introduce our panelists for this wonderful discussion we're hoping to have for you guys today. I'd like to introduce Debbie Pottle. She's a RN care coordinator from Eastport Healthcare, Inc. Ebony Winford. She's a director of research and health equity through the Cherokee Health Systems, and Sandra Aravalo, who's the Director of Community and Patient Education for Montefiore Nyack Hospital. So we just want to thank these three fabulous panelists for today and for leading us through this wonderful discussion that we're about to have. And as Cindy mentioned, we're going to be discussing how diabetes care and health equity have been addressed during this changing healthcare landscape during the COVID-19 pandemic and amidst other challenges. So next slide, please. So at the end of this webinar, we're hoping that folks will understand and have a better understanding about the changes in the broader healthcare landscape on diabetes management, particularly for those vulnerable patients who face greater barriers to their care. We want folks to understand the unique perspectives of healthcare professionals on challenges and successes with changes in their organizational systems and workflows, what you can learn from this, and how to apply lessons learned and best practices for patient-centered diabetes management during this unprecedented public health emergency. So as always, we will be monitoring the chat. Please drop your questions in there, and we're really looking forward to a great discussion today.
Wonderful. Yeah, Vanessa, you can go to the next slide. Great. So we're going to start with our first question. I do want to let each of our panelists give a little bit more background on their role, on the types of patients that they're serving. So it's going to be, we're going to try to stay on time here, but we have a lot to get through. So I'd love for each panelist to take a few minutes again to introduce themselves a little bit more thoroughly and also to reflect on this first question, where we're thinking now even more than 18 months, maybe 19, 20 months, about specific challenges that your health center or health system organization encountered, specifically around diabetes care for your patients. That could be changes to systems, workflows, outreach, maybe a little reflection on what worked, what didn't. So we'll start for this, for the order of this, just going in the order of that slide before. So Debbie, would you like to start?
Hi, I'm Debbie Pottle. I'm an RN, Certified Diabetes Education and Care Specialist at Eastport Healthcare in Maine. So I am the Lifestyle Coach Coordinator for the Diabetes Prevention Program, as well as Instructor Quality Coordinator for the Diabetes Self-Management Education and Support Services. And most recently, I took on another role for a facilitator for a virtual program, Healthy Living for Me facilitator, for those living with chronic disease, as well as diabetes support. So we've had a lot of challenges here at Eastport. We're FQHC. We've been here in Eastport since 1978. And since the beginning, our target population has been the most vulnerable members of our community. We have a high, whose income is at poverty or near poverty, elderly population, and isolated. Persons without health insurance or inadequate coverage of health insurance. So the challenge is that when the COVID hit, everything here at the health center was done in person, face to face. We've had our challenges with even before with access and transportation. But one of the challenges that really became really big here was how to deliver care. How are we going to deliver with COVID, where everything was face to face? And would we even be able to bill for virtual? Some of us were familiar with Zoom as staff, and so we had a whole staff learning curve of how we're going to deliver virtual. How is it going to work? We had to furlough employees in the very beginning, and then how do we bring them back? And I was really concerned for our diabetes population, especially the elderly and those living alone. Internet access here in Washington County it can be very connectivity. It goes down. You never know if you're going to be closed out. And so that's still a big issue today is broadband here. Even where I live 7 miles out of Eastport, I can never know if I'm going to be able to attend a Zoom meeting from home or not because of our broadband. Staying safe at home. Did they have access to food? Did they have adequate supply of medications? Did they have a sick day management plan? Glucose tablets, thermometer, glucose meter, and test strips. And then if somebody was only checking their blood sugars once or twice a day, what happens if they get ill? Do they have enough test strips to check it 4 or 5 times a day? And then one of our biggest concerns as a management team was the depression and isolation, because so many of them are widowed and lived alone, and here COVID hit, and would they have access to, how would the access to family and friends be? And so one of the things we did right away was we all got Zoom accounts. We all got a professional Zoom account that we could get in contact with patients, and workflow change for the MAs that they had to teach. In us too, we had to teach patients on how to use Zoom. They weren't familiar with Zoom. Some of them had tablets, some of them didn't. I still have at least 25 to 30% that do not even have a cell phone or a smartphone. So virtual, the telephone call, the audio became very important as well, so that we could, make sure that we were reaching out to those vulnerable patients.
Great. And Debbie, I'm going to stop you right there, but we will come back to technology. So I'd love to hear more about that. Ebony, would you like to give a little background and context for how the past 18 months has been for your health system?
Absolutely. Thanks again for having me. I am also at a federally qualified health center here in Tennessee, and we have 24 brick and mortar locations as well as a mobile clinic, and our population sounds very similar to yours, Debbie. For those of you all who are familiar with UDS metrics, we quickly saw our diabetes compliance metrics go pew. And it made perfect sense because, as Debbie was stating, we made lots of attempts to reduce our clinic density to ensure protection. We did well visits in the morning, sick visits in the afternoon, as a way to add additional layers of protection. And we are still working to re-engage individuals who have not been seen in over a year for chronic disease management. One of the plus sides is though we collaborated with HRSA and received funding for Bluetooth enabled glucometers. However, they only worked for certain phones, and a lot of our phones get the Lifeline. A lot of our patients get the Lifeline phones. So they call them the government phone. So wasn't always consistently compatible with their phones, but when it was, they were able to upload their glucose reading via Bluetooth to their phone, and it would patch through to our electronic health record system. So that was like mostly a success where technology allowed. Other than that, good old fashioned outreaching, like, hey, we haven't seen you in 12 months. The last time we saw you, your A1C was 13. You know, can we arrange a time when you feel safe for us to give you a medical visit to evaluate that? And that's kind of our ongoing plan now, is working to re-engage people however we can while ensuring safety.
Wonderful, thank you. And Sandra, you want to go ahead and reflect on the past 18, 19 months at your hospital system?
Yes, of course. So hi, everyone. I'm Sandra Leon. I'm the director of now, the new name is Community Health and Wellness at the Montefiore Nyack Hospital. We are in, well, we're in New York. It's half an hour north from New York City. So we're a little bit luckier that a lot of our patients have Wi-Fi, and that has been our biggest advantage, I will say. So, we've been faced with the same challenges, no in-person visits and all of that, and especially during COVID, being that we are in a hospital, people didn't want to even come near the hospital. So very quickly, we decided that we needed to still make our visits and be in touch with our patients with diabetes. So we got into virtual visits, but then we had to change the billing. We had to change, Zoom features, everything to make sure they were HIPAA secure and all of that. So that took us about a month or two to do. And then we had to start reaching out to all of our patients again and let them know that we could see them virtually, or, for people who didn't know how to use Zoom, because we have a lot of elderly patients as well, and they're not very tech savvy. Then what we did was that we created a conference line just for patients with diabetes that they could call anytime, and they could call us through this line that was also, secure. And we started doing virtual visits and phone visits this way that we could actually bill.
Wonderful, thank you. Vanessa, we can go to the next slide. All right, so there's a lot of text on this slide, I know, but so public health emergencies like this pandemic do end up shining a national spotlight on things that already exist in our healthcare, in our culture, so discrimination, racism, bias. I'm curious from the panelists how your health center or organization has engaged in conversations about this, whether that's with your staff, your patients, and have you implemented specific programs or continued specific programs that try to address those unique needs of some of your patient population. When we're thinking about diabetes management specifically, we know that barriers like food insecurity do have a direct impact on that. So if you want to speak to any food insecurity efforts specifically, you're welcome to, but really anything that this pandemic has kind of shown a light on when it comes to discrimination, racism, bias in your areas. Let's switch up the order a little bit. Sandra, do you want to come back in and answer that question first?
Yes, of course. So something that we have done is that we needed to create a list of all the resources in the community, especially for food pantries, soup kitchens, churches, where patients could actually get access to food. So we decided to also do some collaborations with some of these organizations, and that way, we could feel safe referring our patients there. We also needed to make sure that, especially during COVID, these were facilities that were, COVID free, or at least, they were taking some precautions over there. So that was one of the major concerns that we had. But once we created that list, we were able to give the list to our patients and, just tell them where to go for food and all of that.
Wonderful. Ebony, how about from you? Anything specifically that this pandemic has highlighted for your health system? Anything that you have specifically been involved in to address or to continue to address?
So you all heard that my title is Director of Research and Health Equity. So this is my wheelhouse. I am thankful that you put that picture up there that racism is a pandemic, because I don't think we give enough credit to the impact of racism on health outcomes, particularly for Black and Brown people in the United States. We saw exactly the same thing occurring here in our healthcare system. We have a really robust data and IT department such that we can access data on different disparities, including diabetes, hypertension, obesity, depression, across different identity markers. And what we found throughout the pandemic especially is that Black people have less controlled or less well-controlled diabetes compared to white individuals in our organization. Individuals who are Latinx or Hispanic have a little bit better control of diabetes compared to white patients, but the Black patients in our organization have the least well-controlled diabetes. And that's not just because of lack of access to food. Those are the resounding effects of systemic racism in the United States. So we created something called we created a health equity committee, and we now have a State of the Health Equity at Cherokee Health Systems report, which not only summarizes the disparities that we're seeing, but we're also working to identify the root causes so we can identify and remove the barriers to wellness across our groups while understanding the role that racism and bias and discrimination plays. We've also done some things with our LGBTQ organization, recognizing that that's a bias, that's a discrimination. And so one subtle thing we did, which is incredibly meaningful, is that we have trans flags posters in every single clinic stating that everybody is welcome here. And we believe that representation matters. And so that's one small way to combat the bias and discrimination. And we just started that during this time period.
Wonderful, thank you. And Debbie, any reflections on how the pandemic has highlighted different insecurities, different biases, anything specifically that Eastport put into practice or continued through this period of time?
COVID. So, of course, the elderly population and the poverty, and poverty is also can be biased people, and they don't want to admit that they can't afford food or anything else either. And so we wanted to make it that we would provide emergency food bags. They wouldn't have to give income guidelines because that was really important. They don't want to give out their income. The only thing we had to track, because we worked with Good Shepherd Food Bank, so this is who we collaborated with. And the only questions they asked of us is if they had a chronic disease or not. And of course, the diabetes population, hypertension, so it affected a lot. And so we average given, when people run out of money, it's usually towards the end of the month. Social Security checks, EBT cards. So the last 2 weeks of the month is when we give the majority of our food bags, which include milk, canned vegetables, I think tuna, canned chicken, brown rice and soups, I think. So it's an emergency food bag. And so, but anybody can come. They don't have to give a name. Like I said, it's just if they have a chronic disease. And the other big thing that we did was to have fresh produce. And we worked with Good Shepherd again, and through farms in Maine, they would donate their produce. And so once a month, they can come to the health center and we bag it. So there's no multiple, it's bagged and we take care of it. And this month, last month, we received 525 pounds of food and 117 community members were served. And again, there is no income guidelines, no questions asked, just how many are in your household. So that really breaks down that barrier to poverty in that way.
Wonderful, thank you. And just want to note that we had someone in the chat, I think just to the host and panelists, just sharing about their efforts around food insecurity. And so it inspired to me, if there are other programs that y'all are working with that you want to share, things that you've done, efforts, would love for you to use the chat box for that purpose, because we love to hear the efforts of all of our panelists, but certainly lots to learn from each other. So feel free to keep sharing in the chat. Vanessa, we can go to the next slide. All right, so this is a very broad question. So in the title of our webinar, we're thinking about this is a changing healthcare landscape. Some of it was already changing, but what a big impact the pandemic had on healthcare in general. But when we're thinking, we'll start really broad and then we'll get a little bit more narrow about your specific settings in the next question. But when you think about the healthcare landscape of the future, what does that look like for you? I guess your hopes, certainly you can share concerns as well. And that may be in the short-term future or the long-term future. Would love to hear your thoughts on that. Ebony, how about we start with you?
I figured that was my turn. I've been in my head, like trying to check myself because I get incredibly passionate about these things. I'm like, they're not ready for my soapbox just yet. But what I will say is that the future of healthcare for me would include healthcare for everybody, without the United States being the number 1 country with medical bankruptcy in our attempts to provide health. I'll just put it at that. I want everyone to have not only access to healthcare, but I want them to have access to affordable/free healthcare from competent individuals, not just in knowledge and book stuff, but in cultural humility, also in the awareness of historical systems that have contributed to health right now, to people who are willing to look in the mirror and say, yep, I messed up. Here's what I need to learn about that so I can better serve you. But I envision a liberated healthcare system in the future that, again, we can all take advantage of without having to donate our left foot first.
Wonderful. Thank you so much for that. Debbie, what about for you when you think about, it's kind of very broad question, again, vision for the healthcare landscape of the future? You can certainly reflect on whether that's the country as a whole or your corner of Maine, whatever makes the most sense for you.
Well, I think now that virtual is out of the bag, we can't, after the public health emergency, it still has to be an option. The virtual, be seeing them in their own home, them not worrying about transportation, because when we go back to in person, right now, if they need transportation, they have to give 48 hours. When we talk about access and same day appointments, they're not going to get there that same day. So, that needs to still be an option for patients going forward. And moving on, I briefly, the community health worker, that's our vision. In fact, we hired even during COVID, we did hire a diabetes paraprofessional community health worker who's a medical assistant who's doing a lot of the outreach, making sure, that they can get to the eye appointment. They still need the special screenings. And again, having that access to get there. And we're in the process of hiring. We collaborated with the registered dietitian, but we're in the process of hiring a registered dietitian part-time on site. So we're really trying to improve our whole care management and diabetes care. Wonderful. And that's our biggest things. And we are working with the Maine CDC, and we did receive some Bluetooth scales and some iPads to help with. And so again, that learning curve that the MA has, the community health worker, teaching them how to use this technology. And the continuous glucose monitoring, that has been a huge help, being able to have the continuous glucose monitoring and breaking down that barrier of 3 injections daily. They did take away the having to have 4 finger sticks a day, but they're still required to have 3 injections daily before they can get a personal continuous glucose monitor. So, and to be able to monitor them remotely has been it's a game changer. You can see that, you can see it in their time, in real time, and time in range. And so that really is the future of technology with us.
Fantastic. Yeah. And we'll be able to circle back, I think, to some of those points that you're making, Debbie, again, in just a minute or two. But Sandra, what are your thoughts here for the vision for the healthcare landscape of the future?
I definitely agree with both Ebony and Debbie. And something that we're looking at right now is, how to, like, these remote visits, they've been actually very successful. Like even now when we have opened the doors of the hospital again to patients to come in person, people are asking if we're still offering remote visits, virtual visits. I think that that's something that is going to stay, that if technology is definitely there, why not to use it if it's easier for people? As Debbie mentioned, transportation might be no matter how close we are to New York City, there is not a lot of transportation here in Rockland County, and especially public transportation. And patients have a hard time accessing their visits because there is no transportation. So if you can see the patient virtually, why not override that and just see the patients that way? Now, there is a challenge as well, because not every virtual visit or not every visit could be done virtually. There are some visits that you definitely need to see the doctor in person, and the doctor needs to check your ears and hear your heart and things like that. But, if there are a lot of specialty visits that could actually be done virtually. And I think that's the way to go. And as Debbie was saying, for diabetes, we have so much technology right now, so many things that we can use. I'm just scared because I've been thinking, okay, if this is the landscape of the future, what's going to happen if those satellites stop working? But I think that that's the way to go. We just need to be more secure of what that's going to look like. Also, because now we have all these people hacking hospital databases and all of that. So I think that if we are to use technology in the future, we definitely need to improve our security systems and our safety systems and be able to provide, patients with the safety that they need to feel.
Great. Yeah, Vanessa, we can go to the next slide. I think that some of this has been touched on, but I think we can continue to explore this a little bit. It also would be a question I would love to hear anyone in the chat share, because I think it's an important point when we're thinking about challenges that have occurred. There are many in the past, 19 months for health centers, for hospital systems, but there have been some upsides too, if you can frame it that way, of mentioning already transportation, of being able to connect with providers without having to worry about how am I going to get a ride there. There's actually an upside there. And so I'm curious from our panel, and again, from the chat, I see Telemed is here to say yes. So what, if there's any specific policies or procedures that you anticipate, either that have already become sort of a standard practice that you don't anticipate changing, or anything else that you hadn't mentioned in the previous question that you really see, we changed out of necessity, but now we really see the benefit. Debbie, is there anything else you wanted to mention? I know you touched on transportation briefly, but anything else here you wanted to mention?
Again, it's the telehealth staying and how does it work into our, into our daily workflow. One thing we were talking about, this was just in our leadership meeting, about the rate of no-shows and cancellations because they can't get here in person. Before we go and cancel them, can they change? Is it possible to be changed to a virtual appointment? That being able to offer virtual, especially for a specialty in diabetes education, it really cuts down on your cancellation and no-show rates. And that's one thing we're tracking monthly. And last month it was 7 that would have canceled or no-showed if, Christina, the community health worker, didn't reach out and say, well, Deb can do this. How about, we can either I can send you a Zoom invitation, she'll even do a phone call just so that, that we don't lose that point of care and that touch that base. So, so it really does decrease that no-show rate. And how can we work it into a practice, to a workflow practice? So if patients are canceling on the provider, how can we work that into that workflow? But like Sandra said, sometimes patients do need to be seen, but we don't want to lose. You don't want to lose that opportunity. You don't want that missed opportunity that you're not touching base with that patient.
Absolutely. Sandra, anything else you wanted to mention here for your hospital system? Kind of, are there policies, procedural changes that you anticipate will stick?
I think that definitely telehealth will stick, and we have changed all of our medical records, in our systems to reflect that virtuality. So now we have new codes. Now we have, everything has been changed so that we can support these virtual visits. And also we've made changes in the way we practice as educators, as diabetes educators. It's hard to educate people just by talking to them on the phone. So now we have also acquired a lot of things that we could show. It's more like a show and tell kind of type of practice, especially with people with diabetes, because they need to know like portions, how to use insulin, all of that. So there are a lot of resources online that we've been using, but we have been making our own resources. And again, it's like a show and tell. I think that that's very important, that we need a lot more videos out there that are non-branded, that we can use with our patients, make our own, make, as Ebony was pointing at some point, that are culturally humble and sensitive, because we need that for our patients, things in different languages as well, because it's hard to be doing something virtual and then having a translator on the phone, for example. So we need a lot more people from different cultural backgrounds to also be healthcare providers and health educators, that can reach to their own communities. So I think it's, in conclusion, I think it's definitely sticking. Virtuality and technology is definitely sticking, but we have a long way to go.
For sure, for sure. Ebony, any other thoughts in this area?
I'm going to say ditto with the technology. And I want to acknowledge the comment in the chat box where we're saying, yay, technology, but there's still aspects of our community that we can't reach because of technological barriers. One thing that we did is we advocated so much these past 2 years. I know I myself was interviewed a couple times. I work with the FCC. I did a couple op-eds stating, yeah, this is cool and everything, but we need broadband for our patients consistently, particularly those who are on Medicaid, who are already getting the Lifeline phone. Why can't we add in broadband service as well? Reliable broadband service, because we've shown the effectiveness of telemedicine, reducing loneliness, making sure people still feel connected. I'm a licensed psychologist, and I can't tell you the number of times I've spoken with people who said, I so much look forward to you reaching out to me because I can't see anybody. Another component of telemed, which I'll reiterate, I think that Debbie stated, is that we've had digital health literacy coaches, people teaching patients how to use it. And if you'll forgive me, I want to tell one very, very quick story. I have a patient who he's just one of my favorite patients ever. He has diabetes, MS, whole 9 yards, but he's really, really attuned to his body and what it means. But we were trying to teach him how to use Zoom. So he set it up on his phone here in my office, and I set it up on my computer. And we finally got the connection going. And he looked in the computer, y'all, and said, "Am I on the internet?" And I was like, "You are on the internet. This is so cool." And that was his first time being on the internet, but he went and told his whole family about that. He was like, "I told him I was on the internet." And I was like, they may not have been able to see you, but yes, you use the internet. But it's moments like that that I never would have had because everything was face to face. We didn't have to teach people how to access us. The fact that we can provide very high quality care beyond the boundaries of our four walls of our institutions is something that cannot change, because we have touched lives and kept things going, pushing beyond what we've done just because we've always done it that way.
Yeah, excellent. Thank you so much for that. I think that some of your answers definitely are tied into this next question. Vanessa, we can go to the next slide. We'll see what other thoughts might come up here. So understanding accessing technology, whether that's the actual physical piece of technology or internet access, certainly, noting the concern for broadband access. And I know that earlier in our session today, we even differentiated between, in Debbie's area in rural Maine, there's maybe more issues with broadband access than for some of the patients that Sandra comes in contact with in New York. But I mean, there's definitely barriers to care that include technology and include other things as well. So just, I guess, since I know that some of you have already addressed this comment in part, curious, if there's any other thoughts around patients that are facing, for whatever reason, increased barriers to care, whether that's during the pandemic or just in general. Any other special considerations that your health center or organization has kept in mind when you're specifically thinking about diabetes management? Ebony, I'm going to bounce back to you if there's anything else you wanted to add to your last answer.
3 things come to mind. We got our mobile clinic up and running. And instead of expecting people to come to us, we went to them. And one of the main things we've been able to do, particularly with our individuals who don't have homes who access care, is wound care. They ask for wound care because of uncontrolled diabetes, things like that. So we've been going to one of the larger camps here in Knoxville every single week, providing wound care, diabetes checks, hypertension checks, whole 9 yards, and routine primary care if we can, because we have Wi-Fi on the van, so we can connect to a primary care physician to do a visit. So we've done that. We have a brick and mortar clinic that is a healthcare for the homeless clinic where we serve individuals without homes. But when the pandemic first started, we recognized that individuals without homes were at a really, really, really high risk of contracting coronavirus, and we wanted to protect them and our staff. So we cleared out our entire waiting room and put in 4 iPad stations in each corner and little privacy things. Patients could come in 4 at a time and be in the corner, and then our primary care providers would be in the back in the clinic with another Zoom connection, and they would talk. And then 1 at a time, if they needed labs, they would come back and then leave before the next person would come back. So we had to pivot really fast to make sure that we kept access open. And lastly, a couple of our clinics have phone booths in them. That's what they look like. Or if you remember, like if you used to go to the mall and they had the little picture stations, you can go in there, close the thingy and take your pictures. Some of our patients wanted to see, like particularly their psychologists and their therapists, but we did a lot of remote work. So for patients who wanted to and were able to get into the clinic but didn't have technology on their own, they would have their appointment, go to the phone booth, set up the Zoom meeting, and they could see their therapist that way. And then somebody from our staff would be available to sanitize it in between patients, and then they would leave and go home. So we had to find ways to use technology, knowing that not everybody can access technology, but making it available for them. And again, going beyond the 4 walls of this clinic here.
Excellent. Yeah, thank you so much for that. Sandra, any other thoughts here around considerations for patients that are experiencing more barriers to care?
Yeah, something that we started doing was partnering with libraries in the different towns in our county, because they have good Wi-Fi. So we were telling people, if you don't have good Wi-Fi, you can go to your nearest library. And we partnered with the librarians, and they were very nice in helping, especially the elderly that don't know how to log in and all of that, to log in, you know, and kind of navigate the sites and everything that we need a little bit. So that was terrific help.
Excellent. Yeah, thank you for that. Debbie, any other thoughts here for some of your patients that might have difficulties? I know that you had mentioned already a lot of difficulties potentially accessing technology. Any other considerations that you all made?
One thing, Eastport Healthcare is partnering with the city and Maine Council on Aging, because as we talk about, it's an elderly population with chronic health conditions, with diabetes being very high prevalent here. We're working on a weatherization project. And so it's a collaboration. Again, it's going beyond these 4 walls. You know, it's going to be reaching out to that community, because we are a community health center. And, you know, how can we help as a health center? Is it volunteering when the funds ever get approved? I do find that working with different state agencies, there's a lot more bureaucracy, you know, a lot more to it. We just can't go in and, you know, weatherize. You know, there's just a lot of barriers to going in. And, you know, we've been working on, but was hoping to start it. Here it is November, and we're still in the planning stages. So, you know, but weatherization and keeping patients warm, heat insecurity. We talk about food insecurity, but we have heat insecurity here as well. And are they going to, in what's going to impact their diabetes? Are they heat over food over medication? The cost of medications, that has to change. Getting back to healthcare being affordable, medications need to be affordable, because all our diabetes meds that are really effective, many of them cannot afford. And that is just so unfair. So.
Thank you. Thank you. We're going to go to the next slide, Vanessa, but I will say that this is our last full question for our panel, and we will have a few minutes For folks too, I know that there was one question in the Q&A box and some folks sharing in the chat, but feel free if you're thinking of questions now that we haven't covered yet that you'd really like to hear from one or all of the panelists on, please do put those questions in. And again, we'll hold a few minutes for that space shortly. But our last question, again, one that has a lot of sub questions, so you can kind of pick and choose what works for you in your setting. But thinking about who were your partners over the past 18, 19 months? Maybe they're the same folks that you've worked with already, or were there new sort of partnerships? Who were the stakeholders who were working kind of on the front lines with you? There's a lot of, again, sub questions here. But in thinking about your teams, your workflows, kind of the changes that you had to navigate and maybe shifts in the scope of existing, the work of the existing staff to meet the needs of your health center or organization. Debbie, let's bounce back to you. Anything you want to share around stakeholders, partnerships, workflows?
Well, partnerships, we do partner with the community hospitals in this area, and we work closely with them. We've been working with the Maine CDC because, of course, COVID, we are a health center, getting access to vaccinations, COVID testing, that this has become a really priority in this area because one of the hospitals is no longer given the vaccines, and especially with the vaccines being approved for 5 to 11. So there's a whole team, and even me giving up some of my time to go help either with COVID testing or vaccines. I mean, so we got to be open to change, and that sometimes we're going to be asked to do something that we're qualified to do, but it's not that we do on a daily basis. And we do work with our ACO. We work to identify gaps in care, and we can get one-time help for either medication, glucometer, or even I think they've even helped with fuel and help with patient getting the air conditioner last year. So working in gaps in care with other agencies.
Great. Thank you. Ebony, any thoughts on this? This is, again, a broad question. However you want to answer it is great.
We switched up our entire admin, operational, and clinical workflow. One thing that we focus on at our location is the difference between roles and functions. And functions were fulfilled by so many different people, no matter what their role was. So for example, typically our front office staff would be in charge of checking in patients and scheduling them and checking insurance. But when we sent a lot of our team to work from home, they had to learn how to be the front office staff. I became trained in clinical triage because some of our nurses had to be at the front of the building to make sure we were screening people for symptoms before coming in. But patients still needed to get roomed into the room. So I learned how to take blood pressure and weight and all that jazz and knew where to put it. So literally the functions were distributed across so many different people over the course of the pandemic. And let me tell you, our nurses and our front office staff are the real MVP. And if you don't give them chocolate, you need to start, because doing their job has humbled me in so many different ways. And it helps me understand our whole system as a whole. Coding, billing, making sure we were putting the right GT modifiers and things like that on our codes. Like all of that had to change. The way we communicate in the moment. We used to just get up and go talk to each other. Now we use HIPAA compliant, technology to communicate in the moment, even if we're not in the same building. So essentially everything. We all learn how to do pretty much everything in the whole workflow. And I think it's made us a stronger team as a result.
Wonderful. And Sandra, what are your thoughts here?
Well, it was interesting how it worked for us, because in the beginning of the pandemic, since we are all community and education, we couldn't be doing any of the work that we did. So there were some staff shifts, and most of us ended up just working on the floors, helping with patients, helping nurses, so we weren't doing our regular jobs. But then little by little, as things became a new normal, because, it's a new normal, then we started getting back into education, and we started reaching more out to patients and all of that. We didn't have to hire new staff, but with the new regulations that everybody has to have, like the COVID vaccine and all of these, actually, I believe, I think the health system overall lost a lot of people to these regulations. Fortunately, in my department, we kept everyone and everybody's been working hard. But definitely there are some departments that had to hire more nurses, traveling doctors, more people to come and assist with the amount of patients that we had. But I think that was just the rule for every other hospital during the crisis.
Mm-hmm. Yeah, thank you. Thank you all. We're going to go to the next slide, Vanessa, because that's kind of our open Q&A. I see that we do have a question that Sandra indicated she can answer live. So when partnering with libraries and such to provide patients with Wi-Fi for telehealth, how do you make sure that it is HIPAA compliant? Sandra, do you want to go ahead and take that?
Sure. So we can to make sure that it's HIPAA compliant. Unfortunately, I mean, there are some libraries that might like to offer a more private space and they can have a computer in a more private space. Fortunately for us as diabetes educators, what we're doing is education. So it's like going and taking a class somewhere. So that could happen anywhere. Now, in regards to privacy, even if you're seeing the doctor from your home, your children might be passing by, your husband might be passing by, anyone. So we cannot really guarantee that at the other end, everything is going to be HIPAA compliant. We can guarantee what we do, what is going out of our system, but what's happening on the other side is hard to tell.
Mm-hmm, mm-hmm. Yeah, I appreciate that context, Sandra, and certainly, yeah, I can see how it can be complicated, but to your point about the diabetes education, it's similar to taking a class. That's a really interesting consideration for sure. Yeah, to Albert's point in the chat, we have just 5 minutes left. We are going to let Cindy close us out with a few logistical details about CEUs and evaluation in our final session of this series, but just want to give it one more moment in case there's any other questions. I will say the final slide of this deck has contact information for all of the NTAP partners that have been involved in this. If you have questions for our panelists that come to mind after, feel free to email us. We will pass them along because certainly all three of these wonderful panelists have such great experience and knowledge to share that if you think again of questions later on, absolutely let us know. I think with that, I see lots of praise in the chat, which is very, very well deserved. I don't see any other open Q&A. So Cindy, I think we can go ahead, Vanessa, to the next slide. Cindy, you can take it away with any of our final details.
Thank you, everyone. Such a fascinating and wonderful discussion. Really grateful to have been able to sit in and listen. As you see here, we have the link for our evaluation as well as the QR code. Please, everyone, take a minute or two to fill this out. We really appreciate it. And those who are wanting CEUs, please also fill this out. It is required. Next slide. I want to take one last opportunity to invite you to our final webinar in the series, addressing diabetes management during a disaster. And one programming note, for those in Hawaii, the time will be 9 a.m., not 8 a.m., which is on our marketing materials that have been out there for a while now. Well, the continental US is having an end to daylight savings time this coming weekend. Those in Hawaii will not, so the time for you will be 9 a.m. All other times will remain as printed, but please join us. As I said, we're very excited. This is our first webinar coming from our task force fully in Spanish. And please take a minute to do our evaluation. Next slide. Again, save the date for this special webinar, as I've already said, diabetes management during a disaster. I want to thank our panelists. Thank you so much, Ebony, Sandra, and Debbie for joining us. And thank you to our NTAP faculty. We really appreciated being with you today. Vanessa, our final slide. And there you have the contact information for our NTAP faculty, as well as the diabetes website, chcdiabetes.org. Please check it out. All of the materials will be emailed to participants in the next few days. Please check your email. And thank you very much. Everybody have a fabulous day.
Thank you all so much.